Hello, my name is Dr. Daniel Petrylak. I'm a professor of medicine and urology at the Smilow Cancer Center at Yale University. And we presented our data from the ARV-766 study. ARV-766 is a PROTAC, which is known to degrade the androgen receptor. And this was a phase 1, phase 2 trial in castration-resistant prostate cancer. So let's go into the background first. This is a really new class of compounds. ARV-766 is the second generation PROTAC. The first was ARV-110. And the reason why we've gone forth with this particular drug over ARV-110 is that this is better tolerated, number one. Number two, this has a broader range of ligand binding mutations than the parent compound ARV-110. So in particular, the L702H mutation is the one that is targeted by this drug rather than ARV-110. First, what is a PROTAC? A PROTAC is a drug that uses your ubiquitin ligase proteasome pathway to degrade proteins. About 400 PROTACs can take out one androgen receptor, and PROTACs can be made against a variety of different proteins. It's been done with the androgen receptor, estrogen receptor, as well as other types of proteins, but it degrades it. So this basically is a way of overcoming mutations, which are a way that patients become resistant to primary hormone therapy for prostate cancer. About 20 to 25% of men will develop these ligand binding mutations, and it seems to be most prevalent after those patients who've received prior anti-androgen therapy with the next generation anti-androgens. So this trial had two different groups of patients. The first was the phase 1 dose escalation that took patients with progressive castrate-resistant prostate cancer, 2 or more prior systemic therapies, including 1 ARPI. And we started at 20 and eventually wound up at 500 as the final dose. And the primary objective was safety and tolerability. We established the phase 1 dose, and then we moved on to the phase 2 portion. And this was a little bit more restrictive with 1 to 3 prior ARIs and 2 or fewer prior chemotherapies. And in the phase 2 portion, we had a randomization between 100 and 300 milligrams orally per day. The interesting thing about this drug is that the pharmacokinetics initially are linear, but then they flatten out. And then the interesting observation that we made is that for 100 milligrams and 300 milligrams, there was a higher steady state than what we predicted from the minimal preclinical efficacious thresholds that was derived from animal models. So the 100 and 300 milligram levels were selected as our subsequent use. So we took what I'm reporting here today are only the ligand binding receptor mutation patients. A total of 123 were evaluable for toxicity. We're still analyzing the other data. And then overall, 53 patients had ligand binding mutations, and about half of patients had prior taxane-based chemotherapy. And everybody, as one would expect, had a prior ARPI. About a quarter of patients had visceral disease. There were no dose-limiting toxicities, and as I said before, the MTD was not reached. But in the phase 2 portion, we did have 3 patients who had treatment-related adverse events leading to death. 1 was from an unknown cause, 1 was from brainstem stroke, and the third was from disease progression. 7% had treatment-related adverse events that led to dose reduction, and 8% had discontinuations. These were predominantly nausea. It was a mixture of things that led to this. There was really not one specific complaint. But as we see, fatigue and nausea were the most 2 common complaints that we saw. So this is the 50% PSA decline plot. Overall, 43% of patients had at least a 50% PSA decline. Some were close to 100%, and 51% of patients had a 30% PSA decline overall. When we look at the responses, the objective response rate was 30%. Most of these responses are still ongoing. and we're still awaiting confirmation of 2. That's why we've said it's an unconfirmed response rate. So we're still awaiting confirmation by RECIST criteria. So in conclusion, this phase 1, phase 2 study of pretreated patients with castrate-resistant prostate cancer, ARV-766, was well tolerated. It showed promising clinical activity in patients with a ligand-binding domain mutations, and this is warranting further study in castrate-resistant prostate cancer.